Hello, my name is Jackie Fletcher and I'm an independent nurse consultant with a special interest in pressure area care, wound management and tissue viability. In this video, I'm going to be talking about immobility and more importantly, its consequences for the patient and what we as healthcare professionals can do to minimise or prevent this. Patients in hospital can find themselves confined to bed and unable to mobilise independently for a number of reasons. Most typically, immobility affects older patients or those admitted with pre-existing frailty or underlying conditions such as hip arthritis, osteoporosis, hip fracture, stroke and Parkinson's disease. But it can also affect anyone and can be caused by a variety of factors such as serious illness, traumatic injury or following major surgery. And being in hospital will introduce other factors that restrict independence beyond the initial cause of their immobility, such as enforced bed rest or having intravenous lines or other attachments. Immobility can have a significant impact on a person's function and overall recovery. Being in bed for 20 hours a day for as little as 10 days causes the body to become stiff and unable to move. This stiffness can cause pain, which in turn leads to further immobility and deconditioning, including loss of muscle tone and fitness. The deconditioning can manifest in multiple ways, including reduced stamina and fatigue, often with associated loss of appetite, further diminishing the patient's ability to perform activities of daily living. The physical consequences of immobility can vary obviously depending on the patient's age and their previous pre-existing conditions, but those most at risk will be the older, frailer patients. We now recognise deconditioning syndrome as a complex process that has the potential to affect almost every organ of the body. Inactivity can cause deconditioning, reduced mobility, functional incontinence, low self-esteem, a loss of confidence, increased risk of disability. This puts patients at increased risk of pressure injury, falls and malnutrition. These consequences can further result in a longer hospital length of stay, higher rates of readmission or a need for ongoing inpatient rehabilitation, a reduced ability to perform activities of daily living, a lower quality of life, and ultimately increased mortality. We can now explore the impact of immobility by each body system. During bed rest, people can lose 1 to 2% of their muscle every day. This doesn't necessarily sound like a lot, but when we consider people who are exercising or training, we know it can take weeks to build any meaningful muscle or bulk or see improvements in performance in exercise. So these losses are going to take a lot of time and effort to recover. If you're aged 80 and incapacitated in hospital for just 1 week, you can lose 10% of your muscle mass. This is the equivalent to 10 years of ageing. For those patients who are starting to struggle a little at home already, this could then be the tipping point that means they will never fully recover back to where they were. The largest effect is also seen in the anti-gravity muscles, those that help us to stay upright, such as the extensors of the leg, your quadriceps, gluteus maximus and back muscles, which can impact on mobility and function in both the short and long term. These are also the muscles needed when someone goes from sitting to standing, for example, standing up from the side of a bed. To make matters worse, when we consider those sickest patients in the hospital requiring intensive care and those with multi-organ failure, that deterioration is much more rapid. These patients can lose as much as 20% of their total muscle mass within just the first 7 days of their admission. Losses to this extent may never be recovered. Your heart, like other muscles of the body, becomes weaker with stroke volume reducing by 28% within the first 10 days of immobility, meaning that the resting heart rate increases to compensate. Orthostatic intolerance, or symptoms you get when standing up, occur within 72 hours of immobility, leading to a postural drop in blood pressure and resulting dizziness on standing or sitting up. Poor position and lying in bed causes a reduction in lung volumes. Specifically, patients experience a reduction in functional residual capacity, or FRC, which leads to development of atelectasis, or collapse or partial collapse of the lung. This will be discussed in more detail in the session on respiratory complications of immobility, which will be video 3 in this series. Immobility is also associated with a reduction in respiratory muscle strength. This can result in reduced cough strength and increase the risk of developing hospital-acquired pneumonia. This combination of reduced cardiac and respiratory fitness leads to a reduction in overall fitness, with VO2 max, or maximal oxygen consumption, reducing at a rate of around 1% per day of immobility. If you are immobile, the lack of weight bearing through your skeletal system means you lose bone density, with losses of around 2% over the course of a month. Whilst this may only sound like a small loss, this loss of density increases the risk of fracture by up to 20% in the immediate post-discharge period. This is also significant for falls risks, and it's not just post-discharge. Patients may still be in hospital, for example ITU, before going to another ward, so the risk of fracture if they fall is increased in this instance too. It can also take up to 2 years to recover that degree of bone density, so this is an issue which can have long-ranging consequences for our patients. Immobility doesn't just affect physical systems. Patients who are confined to bed often suffer with sleep deprivation. This, in turn, is closely related to the development of confusion, agitation and delirium, all of which can lead to long-term cognitive dysfunction. The physical and non-physical impact of immobility can significantly affect overall recovery and the patient's long-term outcomes. The psychological impact can be significant too. Studies have shown it can cause anxiety, depression, cognitive dysfunction and loss of confidence. And the social impacts of immobility are significant too. They can be long-term. For patients who have been in critical care, for example, we know that less than half are back at work within a year, and a third still require help with daily activities such as getting dressed or going to the toilet. Mental illness also remains a prominent feature for those who have been in critical care, with a third of patients suffering anxiety and depression, and 1 in 5 displaying symptoms of post-traumatic stress disorder for many months following hospital discharge. So, what can we do about this to prevent or minimise these complications in the early stages? Well, with so many consequences of immobility, preventing or minimising the physical decline is essential to improve patient outcomes. The golden rule is to encourage early mobilisation, helping patients to get out of bed as soon as possible. But whilst they are in bed, there is still a lot we can do to help. The key is to ensure that patients are as active and moving as much and as quickly as possible. Regular repositioning into alternate side lying is essential to prevent pressure damage, whilst also acting as an effective position to drain pulmonary secretions and reduce the incidence of pneumonia. This can easily be achieved by empowering patients to help with rolling and repositioning where they can. Little things like asking them to reach for a safety side and helping push themselves to roll over can help. Repositioning is covered in more detail in subsequent videos in this series. When moving up the bed, we can also try to get the patient more active. Patients can be encouraged to push through their legs and move themselves up the bed, or, if this is too difficult, the placement of a sliding sheet under their shoulders can help to reduce resistance. All of these small activities help to maintain muscle, provide weight bearing through the arms and legs, and can reduce the impact of immobility. For those patients where out-of-bed mobilisation is contraindicated or options are limited, there are still other options to use the upright position for supporting rehabilitation and recovery. The hospital bed usually has a number of features which can support patients in these early stages, probably the most important of these being the ability to use a cardiac chair position. This involves raising the backrest and lowering the foot section below the level of the heart, so the patient is essentially placed in a simulated chair position in the bed. The orthostatic challenge provided by sitting the patient more upright means that the heart has to work a little harder, which in turn can help to reduce the deterioration in cardiac function or act as an early challenge for those with postural hypotension. Obviously, this isn't going to be quite as effective as sitting out in a chair, but this seated position does have a number of benefits. The change in perspective allows reorientation of the patient with the surroundings, providing a better position for communication, for eating and drinking, or functional activities where appropriate. Sitting upright can also help open up the lungs and increases lung volume. This makes breathing easier, re-expanding areas of collapse and improving cough efficiency. Sitting up is a really good position, but we need to be mindful that patients may slide down the bed and end up in more of a slumped position. This is important as being slumped like this is actually one of the worst positions to be in when in bed, not only potentially causing skin damage, but, and more crucially, causing reduced lung volumes and risking lung collapse. Optimising the patient's position in the bed to ensure hips are correctly placed helps to avoid this. Some electric profiling beds have an auto contour feature, which ensures the hips move backwards as the head of the bed is elevated. This ensures that the patient isn't pushed forward as the head of the bed rises, preventing the slumped posture and reducing the need for repositioning. It is important to get the patient to be as active as possible whilst they're in bed so that they can maintain as much muscle strength as they can. For any patient confined to bed, movement early on in their recovery journey is key. Good team communication can help keep patients on track to move and get out of bed as soon as they are ready. Ward rounds are excellent opportunities for teams to discuss with patients their progress and how they may work towards their next goals in collaboration with the clinical team. Whilst any movement is better than none at all, ultimately the aim should be to get patients out of bed and mobile as early and as safely as possible.